Having worked in international health for 2 decades, I think the value of communities in the field of health is not new to me. I don't think it's new to anybody in this room, since many of us come from community-based organizations ourselves. Particularly in the field of AIDS, I think we learn to respect, acknowledge, and witness the power of what community involvement, community engagement, and community leadership, I should say, means in the field of AIDS. But sadly, I would say that the lessons from the field of AIDS have not been adopted that wonderfully in the field of health and sexual and reproductive health to the extent that they should be. We give a lot of lip service. There are a plethora of good practices being used in health systems, and the role of communities is one of them. But I don't think we use them to the extent that we can. I'm going to be speaking on behalf of Pathfinder International to some extent, based on our extensive experience over 55 plus years working in the reproductive and sexual health field, about community-based programming and what I'm going to refer to as going beyond systems to further bolster what Owen referred to as the 6 pillars of health systems as they've been accepted. But I'll also talk to you about some examples that Pathfinder has. I will refer to some global examples, but I won't go into details. I think many of you know them, and in the discussions we could talk about them. I will talk about Pathfinder's examples in recent years where we have in fact adopted the synergy between and harnessed the synergy between community systems and health systems to produce better health results for people. Of course, all of us believe that a health system is only as good as the results it produces for the people it serves. I'm not going to define what a health system is. I think I have the official definition, but I'm going to cut it out because of time. But in its 2004 flagship report, the WHO did put forward their 6 pillars, that the building blocks, as they call it, that are widely accepted as the basic elements. And let me just mention them. I'm not putting them up on a slide. Service delivery, health workforce, information, medical products, vaccines and technologies, financing, and finally, leadership and governance, which are very critical in the discussions that we are going to have. However, health systems really sounds like there are 6 distinct building blocks. They really aren't, and that's why it sounds very messy, but it's really a complex array of organizations, people, products, and interventions that intersect. But unfortunately, in all of these discussions, the role of community-based approaches has not been focused on adequately, nor has the discussions focused on the avenues for investing in community-based approaches, which are often recognized as the best, most efficient use of available resources. If those of you have seen the Bill Gates letter, which was, I think, released yesterday on the 3 myths, and one of them, you will find a quotation which actually says that community-based approaches are the most cost-effective ways to work. So not only are the right thing to do, but they are the smart thing to do, is what Mr. Gates believes, and I think this is what many of us in the room believe. We believe that people and communities are not just recipients of services, but are actors influencing and driving the systems themselves. Can we have the next slide? We look at Pathfinder, we look at health systems as an iceberg. There's a sort of formal structure on the surface, but it's only the tip of an underlying, larger, more dynamic system below the surface. And without acknowledging that informal system below the surface, and that really includes community systems, it will be really impossible to harness the potential of a formal health system. Community-based programming is based on the recognition that communities are in the best position to know what they need in terms of healthcare, if somebody would ask them, and often they're not asked, to gauge how the services will be most welcomed and likely to be used, and to make health systems work for them. Community-based approaches include a wide array of practices, including formal cadres of community health workers, to community oversight groups for health centers, to utilizing school, faith-based or other social structures for mobilizing and empowering people to improve their own health and well-being. Over the last several years, community-based approaches to sexual and reproductive health, in particular, have evolved considerably. I know that many of you have seen examples of how well they work in your own countries and in your work. I know I have. In Bihar recently, I've seen how women are prevented from seeking contraception, due to cultural barriers and economic constraints, but having a community health worker who comes home and provides contraception at home, in private, has made a huge difference to women's lives. I've seen the Prachar project funded by Packard and UNFPA, where ASHAs, who are the community health workers, are working closely with young married couples in order to convince them of spacing as well as use of delaying their first pregnancy. I've seen in Tanzania for orphans of HIV positive children how they are provided for care at home, as well as support is provided to the families who are providing help to these children, all in confidence but within their own communities. I've also seen in many countries in Asia, in India, in Bangladesh, in Pakistan, and including here in the Philippines, community health workers counsel pregnant women throughout their pregnancy, on care during pregnancy, on the importance of delivering with a skilled birth attendant, and providing ongoing assistance which strengthens maternal and newborn health outcomes. Our field almost always emphasizes the role of communities in impacting health behavior and outcomes. But nonetheless, there's still a lack of understanding of how community approaches and the systems they rely on need to interact with formal health systems, not just exist side by side. There's still a lack of evidence-based criteria and guidance to enable NGOs, governments, and other health service actors to fully leverage community-based approaches and bring them to bear in support of strong formal health systems. Next slide, please. Some of the longest-standing recognized and national achievements in the field of health, in fact, are rooted in community-based approaches. I think some of you may have read the latest article in The Lancet on community-based approaches and partnerships for health service delivery in Bangladesh. This article points out that Bangladesh is one of the few countries on track to meet the targets of MDGs 4 and 5, as well as the reality that community-based approaches of the government and several NGOs such as BRAC, dating back to the 60s and I think 70s, have played a large role in allowing the country to achieve such positive results. Bangladesh is an excellent example of the importance and potential of community-based approaches to bring about strong health systems. For example, one of the primary pillars as delineated by WHO is a robust health workforce, and yet Bangladesh suffers from a reported 800,000 worker shortage in the public sector. Now, this problem has persisted for decades, but consider what it would be and how much worse it would be without the almost 220,000 community health workers who operate throughout that country. Over the decades, we have learned that community-based programs ensure high quality, reduce cost, help ensure appropriate sustainable care that is context-specific and relevant to the realities of the communities we serve. And it's a model which gives results. I think that's part of our problem. We don't sell our results. And it's a model that is sustainable. You know, how much better can it get? Collective experience and global evidence reveal that community-based approaches have particular value where, and look at the conditions, where health facilities are limited in number, where infrastructure has several lacunae, where access to services is severely hampered, and where there are personal, economic, and cultural barriers that individuals encounter in accessing health services. In other words, there is a dire need for community-based approaches in contexts where limited resources and circumstantial challenges are making the difference between life and death. I think that marks a considerable portion of the globe, and in the case of sexual and reproductive health, we know that socio-cultural norms, attitudes, and beliefs and practices and provider attitudes create additional challenges. In 2011, the Global Fund to Fight AIDS, TB, and Malaria worked with many other partners to come up with a framework on community systems strengthening. Community system strengthening. I'm having a little trouble with the lights, so please excuse me if I'm interrupting myself a bit. The function of this framework was to highlight the critical and yet relatively invisible role of communities in bringing about meaningful health outcomes. And this framework helps emphasize that community systems contribute to health in all aspects. And the Global Fund model includes community structures and actors coming together side by side with health actors in an area of overlap. Now, I'm going to skip very quickly to what is different about the way Pathfinder sees this approach. Our approach is that in order to strengthen either the health systems, we really need to be focusing on a zone of interaction. Can we move to the road area? Between the community systems and the health systems. So activities which strengthen this zone of interaction should serve at least one of the 6 key functions: empowerment and self-reliance, organizational strengthening. Can we go to the next slide, please? Okay, they're all up there. Community networking, service delivery, evidence-based decision-making, and resources for health. So it may seem like a very subtle difference between what the Global Fund is saying. We have actually just tweaked that framework a bit and said, instead of working side by side with governments, we need to find areas where we work together, where there's a dependency, where there's a synergy, where communities and governments, in fact, can come together. And I'm going to give you some examples in closing. The Integrated Systems Framework was developed to ensure that we do not only enhance the interaction between formal health systems and the government, as well as and the communities, but we also work together, which will actually achieve more than what we could achieve independently. It's like the gestalt in a sense. In order to get the best health results, you work together. This approach results in the improvement of local communities' self-reliance, participatory decision-making, improved accountability, access to pertinent information, tailored integrated programs, and all of this is done in a sense, in a spirit, over a period of time where there is mutual respect for each other's capabilities. Let me move to the 3 examples quickly. Let me talk about Tanzania. All my examples right now are going to be based on Africa, but I can assure you that similar work is going on in Pakistan, in India, as well as in Vietnam. In Tanzania, Pathfinder has introduced a social accountability tool to our programs called the Community Scorecard. Many of you may use a similar model. This tool empowers citizens to improve the quality of their contraceptive services through 3 steps. Firstly, to hold a meeting with a group of family planning users so they identify issues. Secondly, a meeting with the healthcare providers and local administrators so that they can share their perspectives. But the most important is the 3rd step, which is to bring them together so that they can talk about what their issues are and develop a common joint strategy for solving the issues hand in hand. So, for example, in Kahama district in Tanzania, there was only one room where patients were seen for contraceptive counseling to postnatal checkup. There was absolutely no privacy, but this issue was resolved after the community met together with the providers, and now there are additional private consultation rooms and the clinic's been expanded. The next slide please is from Mozambique, where in our Strengthening Communities Through Integrated Programs project at SKIP, we've developed leadership councils which foster the development of strong, empowered communities that actively participate in improving the quality of health service delivery. They engage key stakeholders and they work with the religious leaders, civic leaders, the traditional healers and birth attendants, as well as government health workers. And in a sense, these councils build the capacity of local leaders across sectors and create opportunity for dialogue and development of more relevant health policies for the people in those communities. So these spaces for dialogue also clarify what the issues are on all sides and provide a large database of information for decision making, in addition to generating what the options are and making choices. So it's not just about a discussion forum, but it's a forum also to move towards making a decision and then, of course, following up on that decision, so there's an accountability mechanism as well. Of course, there is a capacity building element attached to this in order to build the sustainability of such an approach. And finally, Ethiopia. I'll leave you with this example. I'm trying to be brief. So, ensuring adequate human resources for health and for health service delivery is obviously a key ingredient in the pursuit of improved health outcomes. And what we've done here is to ensure that a cadre of community health workers is developed. In a sense, it's an amalgamation of a majority of things where there is task shifting involved. Now, I don't need to talk to this group about task shifting and the role of community health workers. So I've kept this example the briefest because I think this is an example that most of you are familiar with and are using, as I witnessed in all the sessions I attended where different countries and different organizations talked about how task shifting can contribute to remarkable results in sexual and reproductive health, even in the hardest to reach populations. I mentioned the example of BRAC and the Bangladesh government, but as I mentioned earlier, it's also been done extensively in the area of sexual and reproductive health in different countries in this part of the world as well as in Africa. And yesterday, the Joint Secretary of Health from India very respectfully acknowledged the role of ASHAs, who are the accredited workers who are community-based, selected by the community, not paid, in a sense volunteers, but receiving incentives in terms of making a difference in health outcomes, particularly maternal health outcomes, where there has been some measurement. Now, we responded to a challenge from the Ethiopian ministry to design and pilot effective approaches to enable community health workers to directly provide Implanon, which is, as you know, a long-acting popular method of contraception, but at the village level, including in very remote areas. And thanks to funding from USAID, which supports this program, we are now in a second phase of this effort, and we have designed a training model which emphasizes small trainer to trainee ratios, a competency-based curriculum and ongoing training model which ongoing training for quality assurance, which is a very important element of this entire process to ensure quality and to ensure some degree of standardization with context specificity is a critical element of any community-based programming, as well as ensuring a sub-district level coordination to manage client volume per community health worker and reliable commodity distribution. All of these are in fact steps towards ensuring empowerment, building and harnessing community networks, the ones that are existing and building new ones, strong governance and developing adequate human resources. And what we estimate that our support for and training of community health workers for this approach to delivering long-acting methods of family planning will prevent more than 283,000 unintended pregnancies, more than 27,500 abortions, and more than 975 maternal deaths over the coming 3 years. This has all been documented based on impact estimation tools developed by MSI and all being printed in our publication, which we can make available to you. Let me conclude by reiterating my conviction that the importance of strengthening formal health systems in order to improve sexual and reproductive health outcomes needs to be matched by the importance of integrating community systems and health systems, formal health systems as they are referred to. This goal cannot be realized without building community capacity to be a strong partner. But it is not enough to strengthen community systems in parallel to health systems. Not even to acknowledge the interplay between the two. That's just not enough. We must move ahead in our efforts to secure access to high-quality health services for all by actively encouraging and reinforcing the zone of interaction between community systems and formal health systems, designing programs and projects which leverage the functions driving such interaction. Not only will this result in improved results, but it will also ensure sustainability of the relationship between these systems for the future health of our communities. I'd like to close by acknowledging some of my colleagues, Joseph Petrilla, Carlos Laudari, and Minal Rahimtullah, as well as Sono Aive, who's right here, Annie Keel, and Rebecca Herman. Several people have contributed to this, and I just want to thank them and those who are working in the field. Thank you very much.